is Eric Jackson. I'm primarily a pediatric neurosurgeon, but I also see adults with Chiari. And so putting this talk together, I don't necessarily, when I first did it, I thought, what are the questions that people commonly ask when they come in? And so a lot of these are answers to those questions, although we may not actually ask it as a question. But I think those are the types of things that most people with the diagnosis or when they're thinking about treatment are the things that often come up. No relevant financial disclosures, but I think with something like Chiari especially, there's always some bias in terms of how we think about things. And I feel like even in my career, my feelings or things that I know or think I know has changed over time. And so I think if you have a room of people who treat Chiari, we'll probably all look at things slightly differently, or some more differently than others. But I think so the disclosure is that these are my opinions as we're going through. As an outline, I'll first go over a brief review of Chiari and the diagnosis. We'll talk a little bit about the natural history, things about imaging. I'll hit briefly on the study that Dorothy mentioned, as I'm the local PI for it here. I'll talk some things about both intra-op and post-op imaging, and if there's time, one of the questions that always comes up too is, should I be restricted if I have Chiari malformation? And I'll go over some of the data. Now, obviously, one of the questions that comes up sometimes is, if I don't treat my Chiari, is my Chiari I going to become a Chiari II? And, the important thing is that they're actually different diagnoses. They're not a severity scale. You can have a mild Chiari I, a moderate, severe, but your Chiari I can never become a Chiari II. So there's 1 through 4, and then more recently they've come out with diagnoses of Chiari 0 and Chiari 1.5, which are things that also will be asked about. In terms of Chiari I, and I think Dorothy hit on this too, or I say it's not an ideal definition, I think for most things we really look at if the tonsils are herniated more than 5 millimeters. And some of these points are going to be differentiating 1 from 2 and so on. But typically with Chiari I, you don't really have associated brainstem herniation or anything else in the brain that's abnormal. Hydrocephalus can happen, but it's uncommon, but Syringomyelia can happen commonly. In contrast, Chiari II is usually with myelomeningocele. So if you don't have myelomeningocele, the likelihood of Chiari II is going to be small. But in that case, it's the cerebellar vermis, often the brainstem and the fourth ventricle all herniate through the foramen magnum. And usually there's other brain anomalies. And with Chiari II, typically most patients have hydrocephalus and syringomyelia. Chiari III and IV, these are going to be things that are going to be much less common. Chiari III, it's an encephalocele at the foramen magnum, and so actually cerebellar tissue and brainstem tissue come out. If you're grown up and walking around, you don't have Chiari III most likely. Chiari IV, I actually had to pull this one off the internet because it's the one of the 4 that I've actually never seen or treated someone personally, but that's when you actually have hypoplasia or aplasia of the cerebellum. Now, what about Chiari 0 and Chiari 1.5? I highlight these because I had a patient come to me and ask if I believed in Chiari 0, which their impression was you had symptoms of Chiari but didn't have a Chiari. And that's not exactly what it is. And this was described by Jerry Oak's group down in Alabama, where you don't have hindbrain herniation, but you have a syrinx. So you have to have a syrinx to have Chiari 0. You can't just have symptoms of Chiari. And we think it's probably related to an arachnoid veil or web, so the CSF outflow is obstructed, and that's what causes the syrinx. So it's the same operation, but there is a finding in that area. Chiari 1.5 is kind of a little bit of a mix between 1 and 2, and that's why it was described as 1.5. And that's typically you have low-lying tonsils, and the brainstem and fourth ventricle can be low, but you don't have myelomeningocele, and so you don't have all the other associated anomalies. ultimately what Chiari I, as I thank Al Cohen, my partner for this picture, is really a discrepancy between the container and its contents. So either the container's too small or the contents are too big. And so just kind of like the belly hanging over the belt, there's not enough room for everything. And so that's what causes the problems. And so just on imaging, ultimately, it's where the cerebellar tonsils typically go through the foramen magnum into the spinal canal, as you can see right here. Now, going back to the definition, by a strict definition, it's usually tonsillar descent greater than 5 millimeters, which you can see on this patient here. But really, when we look at it, I don't really like that definition because I think there's all this stuff about common elements, but I've had patients come with their reports, and over time, one report says 5, one report says 10, and they're worried that their Chiari has gotten worse over time. And when you put the images next to each other, they look exactly the same. And it's just that it's being measured differently. And so I've had people come with a worsening Chiari that when you actually look at the films next to each other, it's not, and it's just where somebody is drawing this line, that they then take that line off and measure it from, and it can depend on which film they're looking at or which thing. So I don't really make as much out of the measurement as I do kind of the general gestalt of what it looks like. So are the tonsils round or are they pointed? You can think about something that's compressed is going to be more likely to be pointed as it's squeezed into an area versus something that's very round. What does the fourth ventricular outflow or the foramen magnum look like? If it looks like there's plenty of fluid and it's wide open, you're going to be less likely to have a symptomatic Chiari than if it looks really tight, regardless of what your measurement is. And then the relation to C1, I think that's, especially kind of if you look at this picture here, the canal is really going to narrow at C1. So if your tonsils are going in front of or down to the level of C1, the likelihood of things being tight is going to be much more likely. And so just as an example, here are 2 patients that I've taken care of, one an adult with headache and 2 a teenager with sensory changes. Both you can see have pretty significant syrinx. If you were to make measurements on them, though, their measurements aren't really that bad. And it's more just a fullness. This teenager here, I actually presented one of these cases at oral boards for our residents, and they told me to look for a tumor because they thought the Chiari didn't look bad enough to cause it. Obviously, in both cases, it was from that. But just to the point that if you just got a report that gave you a measurement, this may not sound that bad to you, whereas by imaging, it is worse. Now, what about how often does this happen? And I think this is another important thing based on people who may come to us with headaches and imaging that shows a Chiari. So different studies have shown different things, but up to about 3.5% of the population may have a Chiari based on studies. And I think these numbers are probably going to go up based on more people getting MRIs. So CAT scan, people don't notice it as much. So I think if you think about things, the prevalence is probably higher in 2018 than it was in 2000 because of more people getting MRI scans. The prevalence does appear to be a little bit higher in pediatric studies, and I'll get into that. There's a slight female predominance, and I think the important thing here is it really is a common incidental finding. And there was one study that showed only about 1/3 of the patients that on imaging had what was described as a Chiari malformation. Only 1/3 really had symptoms that were felt to be attributable to it. So we tend not to be in a rush to treat the imaging, but rather think about treating the patient. So back to why the prevalence may be higher in kids. This is a study from Cormac Mara's group at Michigan, where they looked at imaging across lifetime. And what you see is the average tonsil position by age. And what we see is probably in early life, it can potentially go down. And as we get older, it tends to go up. And that's probably why you're going to see more Chiaris in a younger population than an older, because just as brain atrophy starts, you probably make more room. So the contents maybe get smaller, so it goes up. Again, this is from Cormac Mara's group out of Michigan. They looked at their imaging database and looked at a number of patients with Chiari that were being followed conservatively. And of that group, only 10% actually went on to have surgery. So a large number of patients who had Chiari follow up for an extended period of time either clinically or by imaging, stayed okay and didn't have problems. The majority of the patients stayed asymptomatic, and interestingly, 3 of the patients, the syrinx actually got better on its own. They did had CSF flow studies, and I'll talk about flow studies a little bit later, and there were some changes in them, although most of them that they had, the majority stayed stable, and they really didn't see much of a change in the mean herniation in this group of patients. Now, that being said, the natural history can be interesting. This is a patient I saw who had cystic fibrosis and got this MRI in 2006 that showed a significant Chiari malformation. He was never sent to neurosurgery. I don't know if it projects that well. In 2013, his pulmonary fellow noted that they'd seen this and decided to send him for another MRI and send him to neurosurgery to be seen. And I don't know how well it projects, but down here his tonsils are way down here, and here they're up here. So you can see change over time. And I think the most likely is if you look at the shape of the base of the skull's coming to here. Now it's kind of angling a little bit more down, so the container's changing, so there's more room for it. So sometimes when people ask if it's, why not treat it just because it's there? Well, it potentially could even get better on its own, although from the Michigan study, not necessarily. In terms of flow studies, I think when these first came out, because I'll often get questions about, well, should I get a flow study? Do I need to get a flow study? When these first started, I think people thought this was going to be the next big thing, and if you had an abnormal flow study, that this means you need surgery, and this is how we're going to decide who needs surgery and who doesn't. The problem is we have a lot of patients who have abnormal flow studies who are asymptomatic. So an abnormal flow study does not necessarily indicate that the patient has a symptomatic Chiari. We'll sometimes get calls from referring saying, this patient has an abnormal flow study. We need to get them in right away because they're concerned, and they actually don't really have symptoms. What I used to take flow studies for was whether or not it was normal. Because I think in most cases, if you have a normal flow study, the likelihood that they have a symptomatic Chiari is going to be fairly low. Now, I have an example of why that's not necessarily the case, but I think more so that's probably still more true, that a normal flow study is helpful in saying probably not symptomatic Chiari than I think an abnormal is for symptomatic. I think one of the problems is it's very institution, technologist, and radiologist dependent. Here's an example. This is a teenage male I'd seen after a few years of symptoms. He had decreased sensation on the left side, right hand weakness, had difficulty lifting his arm, some imbalance, but was too busy to get an MRI. So he presents, unfortunately I don't think this projects very well, but pretty much all you can see of his cervical spine is a syrinx. But so we did a decompression. He was working 3 jobs, anxious to get back to work. So after the decompression, he has a fairly dramatic result in terms of the syrinx getting much smaller. Here the whole cord is. Now you can actually see cord. There's still some syrinx there. There's plenty of room here, as you can see here, compared to there. We got a flow study, and this is the report, which pretty much says, despite the fact that it looks a lot better, there's no improvement in the CSF flow. So I went to talk to one of the radiologists, say, how is this possible? The syrinx has gone away, all of these things, and when I actually looked at it with different radiologists, said, the study's off center. So it's one of those things where it wasn't looking in the right place for flow. Because I had a different patient the same day who it looked tighter to me, and that study showed flow, and this one didn't. So I think it's hard, it makes it hard for me to trust these studies too much if they take it a little bit off center and it changes your result. On the opposite side, here's a teenage female who presented with tussive headaches who had this image, and her flow study was read as normal. And she had clearly tussive headaches to me. And one of the things I wonder, and I talked to the radiologist about, is clearly one of the tonsils is going lower. And so in this case, are we seeing the flow study where it's normal? And if it were off to the other side, would it be abnormal? So I think it really is something where you have to really look at the whole picture with the interpretation. And a flow study may help for adding a little bit of information, but I'd say it's pretty rare that a flow study in and of itself is going to change my opinion about whether or not to treat a Chiari. And this is that patient post-operatively. Now, what about where does Chiari come from? And a lot of people talk about it being a congenital condition. I like to say more developmental, because I think there's a lot of patients who they're not necessarily born with it. So congenital to me implies born with it. Whereas I've seen a lot of babies who don't have a Chiari, and then when they're 3, they do. And I say more developmental because I think it's part of their normal development in terms of how their bone is growing. So it's not anything that's being done by anyone or what happens, and it's probably destined based on genetics to happen, but it's not really congenital in the sense that you're born with it. And then versus acquired condition. Acquired most commonly are going to be from things like lumbar punctures, LP shunts, or intracranial hypotension. The reason why that's important is obviously in terms of how we're going to think about treatment, and I'll come back to that in a little bit. In terms of the classic Chiari I presentation, obviously there's long lists of things, and I don't need to detail all of them. I would say the most common classic symptom is going to be the tussive headache. And all of these neurological symptoms, which can either be from brainstem compression, sometimes from syrinx, or any, those are usually kind of the etiology. The hard thing is so many of these symptoms overlap with other etiologies of symptoms, so it can become hard to figure these things out. Now, in terms of age differences, and as someone who sees both patients with adult and pediatric, I think the main differences are really going to be in the young babies, because those are the ones who are going to present with the oropharyngeal dysfunction, so things like reflux, difficulty swallowing, snoring, apnea, or stridor. Typically, it's hard to get to a very old age with those symptoms if you don't have them treated. So oftentimes they present before that. Kids obviously are also more likely to present with scoliosis, because scoliosis only happens as you're growing for the most part. Once you're done growing, you're unlikely to develop scoliosis. In that regard, I would say older kids and adults are more likely to present with the headaches and neck pain, as well as motor and sensory changes. And I would say in my practice, and some of it may just be time to develop the diagnosis, but more of the associated diagnoses like dysautonomia or EDS or things are going to be more common in the older patients, whether teenagers or adults. In terms of scoliosis, there's a couple of studies that have come out recently that say that this syrinx needs to be the link between Chiari and scoliosis. I think there was a period of time where people would treat a Chiari for scoliosis in the absence of Syringomyelia, and I think there's some new data that suggests that the Chiari probably causes the syrinx, which then causes the scoliosis, but it's not clear if there's no syrinx that the scoliosis is definitively related to the Chiari. When I think about Chiari I malformation, I think really the biggest challenge is deciding who needs an operation. And I said, again, it's one of those things where the prevalence in the population, and often the prevalence in the population of the symptoms, especially things like headache, are so common that there are going to be a large number of people that have both, that they're not necessarily related, and doing a Chiari decompression isn't going to make them any better, so they're not going to like you very much, because it's not necessarily a fun operation if you don't need it. So, like we said, in terms of the literature, the majority of incidentally found Chiaris are probably asymptomatic, and so it's not really worth operating if it's not going to make anyone better, if the symptoms aren't related. Depending on the surgery you do, there can be varied rates of complication. So it's really one of those things that the people who you see the first time in clinic, really the people who are going to talk about surgery on that first visit are going to be the ones with the very classic symptoms or a syrinx. The ones that aren't as classic usually like to do some other workup, because in my general feeling is if somebody else can make the symptoms better with medical treatment, it's probably not from the Chiari, because the Chiari is an anatomical problem, and I don't think Topamax is going to make your Chiari feel better. And it's really important to consider the whole picture and take everything into account. You know, these days in medicine, we talk about precision medicine and patient individualized medicine. I think a lot of that is more directed towards cancer therapy, but I think Chiari is really one of those diseases where it really is a perfect example in terms of not only deciding who to operate on, but what the right surgery for each patient is. And we'll get into that a little bit more in terms of the next question of, you know, what surgery should we do? So here's an adult female I saw who presented to me with classic tussive headaches and has this scan with this Chiari. At the same time, if you look at the MRI, you see the pons is a little bit flattened and the mammalopontine distance is decreased. This raises concern for potential CSF hypotension. So she had an MRI 4 years ago, and if you look, she didn't really have much of a Chiari malformation at that time. She's older than 50, so based on this, her tonsils shouldn't be getting lower based on natural history. So there has to be something else going on. So we got an MRI with contrast, and you can see she has diffuse leptomeningeal enhancement. So this patient has CSF hypotension. And if we do a Chiari decompression, we'll probably fix her headaches for a short period of time, but then the tonsils are going to sink lower from the CSF hypotension, and she's going to be back in the same situation. So this is a patient that I actually refer to my colleagues in IR who actually do directed blood patches. And so she's, I would say most of the time people feel better after the first one, but it doesn't necessarily fix it long term. You may need more than one. But if we look at her MRI in 2018 after 2 blood patches, you can see comparing, the tonsils have actually come up some, and the leptomeningeal enhancement is decreased. So this patient's Chiari symptoms were fixed by blood patches, not by a Chiari decompression. So you really want to treat the source of the symptoms, not necessarily the symptoms themselves. Here's another patient who I saw who actually gets regular MRIs because she has MS. And between 2016 and 2017, her cerebellar tonsils went down. Also between these 2 scans, she developed headaches while straining. Hers was a little bit less classic, so we ended up putting an ICP monitor in, and she had grossly negative pressures. So she also got blood patches done by our IR group with improvement in her Chiari symptoms. So these are things where really, I think historically, a lot of these patients would have just gotten a Chiari decompression, and it would have worked for a while, but are these patients who potentially are failing Chiari decompression because we're not treating the primary source? On the other hand, here's a very classic Chiari I case of a toddler female presented with 2 years of neck pain brought on by coughing, straining, laughing. Pain is worse when she has a cold, usually lasts about 5 to 10 minutes. So that's a good distinction for our patients with Chiari headaches versus a migraine. Typically, a pure Chiari headache tends to be short-lived around the time of straining. Not necessarily I wake up with it, it lasts all day, I go to bed with it. And this patient also snores. These are the patients when they come in with this story where you talk about surgery at the first visit. Immediately post-op, she actually didn't want any pain medication because the neck pain that she had now was less than what her headaches were. Her scan looked good, and the cute thing about operating on kids is you get cute pictures when they're feeling better. So now we talk about surgery and what to do. So obviously for Chiari, we're going to do a foramen magnum decompression. And here's one of the areas with the randomized trial where you can talk about bony decompression alone. Most people, when they do that, will also do some type of cutting or splitting of the dura without opening it, versus bony decompression with dural decompression and graft. If you're worried about a syrinx, some people open the arachnoid and try to identify the obex. You can add tonsillar cautery. And what I say here is if somebody's tonsils are going way down below, I'll sometimes prefer cauterizing the tonsils to bring them up rather than taking C2, because I think in the long term by taking C2, there's probably a higher risk of destabilization of the spine. I personally have not done it, but some people also talk about tonsillar resection. I think in general, the way I describe it to my patients is the more surgery you do, the higher likelihood of success, but also the higher likelihood of complication. And that's where the current trial, thank Dave Limbrick for the slide, of the posterior fossa decompression versus posterior fossa decompression with duroplasty. And I can say we are one of the sites, and we have enrolled all of our patients, so we're happy about that. In case Dave watches, I can't tell you what we've been randomized to. But so the idea is, do we just remove bone versus opening the dura? And, what this comes from is, originally in my training, everyone opened the dura. And, I think there was potentially a higher rate of complication with that. And so some people shifted towards not. And you can see here's a patient that was treated by one of my partners here. And the main thing to highlight is this syrinx here, which 4 months later with a bone-only decompression has decreased in size. And so my take from this is that what this study is going to give us is a better ability to counsel our patients beforehand. Unfortunately, I don't think any study is necessarily going to give us the answer of you should do this or you should do this, but I think it's going to give us better numbers in the sense of if we don't open your dura, there's this chance of having to take you back versus this chance of complication, and if we do, there's going to be a higher percent likelihood of success, but also a higher likelihood of complication. And so in some ways help the patient decide, would I rather have the risk of having to do it again versus these upfront complications, is the way I think about it. But I think, and what I alluded to before, is I think really this goes back to patient selection and picking the right operation for the right patient, and that I think a bone-only decompression is going to work better in some patients than others. For instance, what's good bony anatomy? So if I look at a film and I say, what patient is going to be likely to do well with a bone-only decompression versus dura? And I think two things I really think about are C1 indent. And what I mean by that is you can it's not as much on this film, but I'll show another one, where when you see C1 and you actually see the tonsils curving around it, like C1 is impinging on it. The other thing is when the base of the skull is kind of flat, so it's going straight in. And those are things where you look at and you say the container or the bone really seems to be the problem. And here's a good example of that. This is a patient I took care of that I did a bone-only decompression. You can see there's this little knuckle of bone here. He's nice and free down here, and he's not that bad here. You can actually see he has some signal change in the tonsil here, but right here, there's that little spicula bone that's pushing in. And so we did a bone-only decompression, and it's nice and free now, and his symptoms went away, and he's doing great. And so that's one where obviously you don't want to take the extra risk because you think you can treat it. On the other hand, I feel like patients with retroflexed odontoid, which means the odontoid, which is part of your cervical spine, is coming forward and actually bending in and compressing from the front. I think in these cases where the space is really already narrowed so much, you really have to make as much room as possible in the front if you're going to try to avoid having to do something from the front. You have to try to do as much as possible from the back to avoid doing something from the front. So, here's something where with a wide bony decompression with duroplasty, you can actually make it so the room in front of the spine actually can increase. So one of the other questions that comes up, and sometimes people get differing opinions, is do you up front have to do something from the front? And I think most of our group and people I've worked with would say start with a good posterior decompression, and then if that doesn't work, you can talk about the front. These are also patients where you sometimes would worry about bony instability and may want to get some imaging to work that up. In contrast to that patient, this is a patient I took care of who had a bone-only decompression at another institution with retroflexed odontoid. So you can see again right here where it's pushed, you can see how the bone has been removed. And she came in, she saw me about 3 months post-op and really had never had any improvement in her tussive headaches. So we talked about that. I thought we could potentially do something more from the back with opening the dura. And so we took her to the OR for that. And this is an intraoperative photo, and what you can see here, so here's kind of cotton just to prevent blood from getting in. This is the top of the head, bottom. Here are the bottom of the tonsils here. So we've opened the dura here. And
not showing up whatever you're doing on the screen.
oh,
Do you have a pointer?
yeah, there's an arrow that's can you see that? So cotton above and below just to prevent blood from running in. And you can see here's the bottom of the tonsil. You see we've opened the dura and it's still going below. So, my philosophy is if you open the dura and you haven't gotten the extent of the tonsils within it, it's probably unlikely that you're going to fix the problem. So this is a case where I think tonsillar cautery is helpful. So we shrank the tonsils, and now that you can actually see the brainstem in front of the tonsil, and the tonsil is now up versus before it wasn't. And then post-op now with the duroplasty, you can see there's plenty of room, and with comparison, oh yeah. So here's they didn't have a T2 before. So here's the pre-op, here's the post-op. Obviously she flexed versus extended, so that may make it a little bit better, but obviously there's a difference, and her tussive headaches went away. So I think that population where it's really tight on both sides, I think the likelihood of success of a bone only is going to be lower. So those would be patients I'd potentially counsel towards just doing opening the dura up front. In terms of intraoperative imaging and using things like ultrasound, it's funny because if you talk to different people, movement or pulsatility of the tonsils, in some op notes sounds like a good thing, and in some op notes sounds like a bad thing. So I'm not really sure what it means. So I tend to like to look at how much CSF space is there. Does it seem like there's room, and use that in terms of guidance. So here's a toddler I took care of who previously had an ETV for a big head, and for those who don't know, that's an endoscopic third ventriculostomy, which is a treatment for hydrocephalus where you make a hole here for a fluid bypass. But he has some questionable breathing problems, and his tonsils look like this. So ultimately we decided to take him to the operating room, and here's the ultrasound that we got at the time, and you can see here's the dura and here are the tonsils, and there's no space there. So I feel like if we don't open the dura, there's no chance or a very low likelihood that this is really going to get much better. So we elected to open the dura on him, and his breathing problems did improve. On the other hand, this is an adult female who had a long-standing history of likely symptomatic Chiari, who by imaging, I thought there is no way that I'm not going to be able to open the dura on this patient because it just looks very tight. You see the tonsils coming down in front of C1, and we did an ultrasound there. Now, I guess it unfortunately isn't projecting the picture, but when it comes back to the stop, I can... But what I was trying to show was that there is actually, okay, there we go. If I can pause it there. There's actually a good amount of CSF space posterior to the tonsil, so that's potentially, in my mind, going to be more likely to work. People also ask about imaging post-op. How soon should you get an image? What does it mean? And I think it's important to know that it can really take time to see changes. If you get a scan right away and it doesn't look good, that doesn't mean you need another operation. Here's one of the patients I showed before with the retroflexed odontoid. And she came in with symptoms of chemical meningitis a couple of weeks later, which I would say is probably one of the more common things I see after dural opening, especially the more you do if you're shrinking the tonsils or things like that. And you can see it doesn't look so good. Like, it doesn't really look like much was done. We see a little bit of pseudomeningocele. The tonsils are still low. Kind of question, what'd you do? Short course of steroids, and no more surgery. This is what it looks like 3 months later. And you can see very well decompressed tonsils. She's the one that you can actually see a little bit of room in the front there. So it is something where you do have to give time to see what happens with healing rather than, I think, reacting and operating based on just kind of a very quick scan. So in terms of these things, what I would say is that Chiari is a very common incidental disorder. typically the symptoms are going to be from crowding at the foramen magnum and altered CSF flow at that area. And it's really a discrepancy of the contents and the container. I think patient selection is really key in that if the symptoms aren't from Chiari, you're not going to make them any better. And and I think that's an important detail. I think in terms of surgery, the results can be dramatic if the symptoms are really from it. And we really have studies ongoing to determine the optimal surgical treatment. But as I was alluding to before, I really think it is something where there's probably a best surgery for each patient in the sense of, I approach each operation the same way, but each patient is probably going to get a slightly different surgery because ultimately the goal is to subject everybody to the least risk to get the most benefit. So a patient who doesn't need their dura opened is going to be better off with a bone only. Somebody who just a duroplasty without shrinking the tonsil, every step you do adds additional risk. So it really is something where you want to do exactly what they need and technically not more. And everyone's going to be different in that regard. So I don't know if people have questions about that stuff. I do have some additional slides about restrictions and what people do with Chiari if there's time or if people want to go through that. Dorothy, has time or to... Okay. So one of the, and I'll skip through these slides because there's a lot of them, but one other common question I get is, can I participate in sports? Can I go on roller coasters? What are activity restrictions? And a lot of it is, what's the data for these things? So a lot of people ask it, but what do we really know? And then why do we care? So why do we care about participating in sports or trauma? And really it's because of a concern for a significant life-altering injury. There's a lot of data on cervical spine that if you have a narrow cervical spine, then maybe you shouldn't participate in things. And is that true if it comes up? I think with the data, though, it becomes a chicken and egg question. And in some ways does the Chiari make a traumatic injury worse? Or in some cases, does the trauma cause or make the Chiari worse? Or is it some kind of combination of the above? And I give one example of a patient I took care of who came in because a TV fell on his head. And so had a crush injury, and we elevated a depressed skull fracture. And we got an MRI just to follow up on it because we don't like to do CTs on people, and especially kids because of the risk. And what we find here is after the television fell on his head, he now has tonsillar herniation. So did he have that before, or is this something that just kind of the crush injury actually caused it? Of note, we have had images since, and the Chiari decompression is no longer there. So in terms of the data, there's some case series, and I'm not going to go through all of them, but there are different percentages based on patients who had a trauma as the precipitating event for their symptomatic Chiari. There's been a bunch of opinion papers on it. Most of them will say if patients are asymptomatic, then it's not absolutely contraindicated and people can participate. But as the paper out of Boston Children's said, the data is sparse and most people just say it out of experience. The interesting thing is most case reports come out and say to restrict. And I'm going to quickly go through these slides, but I kind of went through a number of the case reports and all of the different ones for putting this together to try to sort out, is there anything good in these? And so a lot of different cases. In summary, what I would say is there's multiple patients, although none of them prospective. So what that means is none of these patients were known to have a Chiari before and then something happened. It's all patients who presented either with some kind of trauma or change and were noted to have a Chiari at that point. Interestingly, some of the case reports kind of ignored the fact that the patients had synostosis and hydrocephalus and still blamed the Chiari for it. And then the other interesting thing is most of the patients who didn't have death at the time of presentation often recovered. In terms of other types of data, there's surveys, and so there was one that pulled the ISPN, which is the International Society of Pediatric Neurosurgeons, and another one who looked at the AANS CNS pediatric section, so a U.S. group, and just asked pediatric neurosurgeons, do you restrict your patients? Interestingly enough, the international group is much less restrictive than the American group. Now, whether that is a medical legal comment or just a difference in philosophy, but only 20% of the international group and about close to 40% restricted in the U.S. Now, there's really been two studies that have come out more recently, one out of Boston Children's and one out of Michigan, that actually looked at sports directly for patients with Chiari. And again, because of time, I'll go through quickly, but the Boston study was a purely retrospective study that they contacted all the patients who were diagnosed with Chiari between 2008 and 2011, sent them surveys, and figured out how many sports seasons did they participate in, and kind of did athletic seasons and then collision sports, which is a little bit different than what the definition for contact sports. But what they found is they had 0 respondents in that who had kind of a serious injury, whether death, coma, or paralysis related to participation in sports with a coma. There were a couple of patients who had quote paralysis. One had a Bell's palsy, and then another one who had some paresthesias. And then a number of patients did have concussions during that time, but nothing felt to be related. And then they didn't count, one patient had cancer, so that was felt not to relate. So their conclusion was the risk of catastrophic injury is very low, but you still have to do it on a case-by-case basis. The other study out of Michigan was both a retrospective and prospective study, and they looked at patients both at Michigan and at Mayo Clinic. They used the AAP definition of contact sports, with dodgeball being my personal favorite, with the scene from the movie. I don't know if I need copyright for that, but so what they did is they had 569 patients who participated in sports. They found that the groups weren't that much different between what their tonsils looked like and also whether they had a syrinx or not. They also had a group that they followed prospectively. There were 33 concussions, and one patient who had symptoms that were felt to be other than concussion, but not necessarily felt to be Chiari related, although they did include them so the reader could decide what they wanted. But again, the numbers here are either 0 or 1, very low in terms of people who had problems. And in the prospective registry of patients that they followed for about a year, they didn't instruct anyone to stop. Pretty much all of them continued to do it. One patient had a concussion. A number of them had surgery, but none of them had significant injuries. So what they talk about out of this is that their plan is to continue what they call a permissive practice, which I think is similar to what I do, which is if someone has a very large syrinx or clear symptoms, the recommendation is to not participate or do those type of activities and have surgery. I think the reason for that is, the analogy I use is kind of like how far you're standing from a cliff and how much wind it takes to push you over. And if you're symptomatic, it means you're already kind of close to the edge there. And so it's not going to take very much, whereas if you're asymptomatic, you probably have a little bit more leeway or room. So most people, if they have surgery and everything improves, they then allow them to go back to normal activity. And people who are asymptomatic aren't treated and aren't restricted, but do have to have a real conversation about that. We don't necessarily have good data. You potentially are at higher risk than the general population, and you just kind of have to weigh the pros and cons of how important is participation to you. To summarize the data, and so I use quotations about the data because unfortunately none of it's necessarily level 1, is that bad things can happen to patients that have Chiari malformation, and it can happen with or without trauma. And it's not really clear that the risk is significantly higher with participation. It probably, theoretically, it has to be higher, but that it's enough to to restrict people to take away the wellness benefits that they may get from participation. But it definitely is a case-by-case basis. And it's fairly infrequent that I quote an ethics paper, but this was one written about Chiari in sports. And what they kind of say is that it's ethically permissible to allow asymptomatic patients to do it if you counsel them and they understand the risks. And so go back to the take-home, all the things I already said, and then I just added the line that no real prospective data that asymptomatic Chiari patients truly have a higher evidence of injury, although there are case reports in a retrospective fashion that suggest it is possible.
Thank you very much, Eric.